Good morning, everyone. I am Yvan Borbat. I work as a gastroenterologist in Clinic Saint-Luc in Brussels. I really want to thank Suzanne Ribeiro for inviting me to give this talk. I am honored to participate to this meeting. I will explain and discuss with you the role of EUS in GI cancer staging in 15 minutes. I have no disclosures to declare. The agenda today, we will go through esophagus, stomach, pancreas, and rectal cancer. And I will start immediately by the esophagus. There are, as you know, two types of esophageal cancer, adenocarcinoma and squamous cell. Both are with varying degrees invading the lymph nodes. And this invasion is clearly related to the invasion of the esophageal wall. And this is depicted here with the various staging T1, 2, 3, 4A, 4B. Now, what is the role of EUS in this respect? EUS is a very...
So Ivan, do you stay? Because we still have questions. I would love you to stay online if possible. Okay. And then I think we can go to the narcose. Thanks. Because the narcose is on a case that will be presented by the people in the room. And as I told you, it's Dr. Ribeiro performing. And then Dr. Dominique de Wolf from Delta Rouselaar should be in the room as well.
Hello, do you hear me?
Yep.
Yeah, I'm here with Dr. Dominique de Wolf. We are doing a case that the assistant are going to present now. So we have to talk, of course, with the patient about the risk and the benefits of it. Most of the lesions, they don't progress if they are leiomyomas, we think they are. But of course, our most fear is that we are following up something that could that have malignant potential, but which doesn't seem to be. But we have always to keep in mind it.
So I think if you can confirm a benign lesion, a leiomyoma, and he has not too many problems for eating, I think it's not a bad option to just follow it up, because an endoscopic resection of that kind of lesion is nearly impossible. It's too big. So we have to do a surgical resection. It will be quite difficult, I think.
As an echoendoscopist, I was happy to hear that for pancreatic cancer, you almost always do EUS. Is that true? Did we hear that correctly? Because here we got referral of those patients that there are questions maybe about the operability, or maybe we need a biopsy, but you don't get every case for EUS.
We had this policy for many years. It is local, I would say, demands by our surgeons, because as surgery is such demanding and has high morbidity and mortality, as you know, we do want to have diagnosis beforehand. And it's also linked to the fact that we have access to endoscopic ultrasound and good expertise. I would advise to do the diagnosis, because as I told you in the presentation, so many cancers are borderline at diagnosis, and so few nowadays are really readily resectable that you should puncture, and it allows you to give you, of course, the diagnosis, but also look for some molecular features that you would be happy to have up front. So, yeah.
Do I understand correctly that you puncture even in a resectable lesion if you don't consider upfront therapy? Because we stage, but we don't puncture here. We puncture if we want to treat neoadjuvantly, or but if we know that we go for upfront surgery, we usually don't.
Well, it's not mandatory, but you do EUS anyway, and you have a proper staging. That's what you do, and in the same time we puncture. Yes. Always happy, and the surgeons now, we had sometimes, weird findings like lymphomas or other types of aggressive neuroendocrine cancers or so. So yeah, because we do the EUS anyway, we puncture. But I would not say it is like a strong recommendation, but I think in the future it will become a recommendation.
Show something, or do we still debate a little bit? They are ready to show something. So Ivan, do you stay? Because we still have questions. I would love you to stay online if possible. Okay. And then I think we can go to the narcose. Thanks. Because the narcose is on a case that will be presented by the people in the room. And as I told you, it's Dr. Ribeiro performing. And then Dr.